I think we're going to talk about new trials, but you're aware of other new trials looking at Crohn's disease, which are coming.
Yeah, so I think, there was always a feeling for many of us that biosimilar companies, still have a huge income generation revenue coming from this, that there should be a requirement, at least is for somebody to do a decent study in inflammatory bowel disease that involves both a primary study and potentially even a switching study. And I'm certainly aware of one trial that was funded by the biosimilar company around CTP13, it's biosimilar to infliximab. And I think some preliminary data have been presented at DDW this year.
For our listeners and viewers, just take through just some basic characteristics of that study, because I agree that's an important piece of evidence that we've been waiting for. Whether it's the definitive trial, I think it was open to some discussion. But this is a clinical trial, randomized control trial, looking again at non-inferiority and efficacy and overall safety of specific biosimilars, again, CTP13, which is branded as Inflectra in Canada, versus the innovator version of infliximab, which is Remicade, in patients with active Crohn's disease, and the total study duration is 54 weeks. So it's a phase 3 randomized double-blind parallel group trial. Non-responders get withdrawn at week 14, and there's an accommodation for dose escalation up to 10 milligrams per kilogram from week 22 if disease is worsening. So out of the gates, this is a head-to-head comparison of the biosimilar to the innovator, followed out to 30 weeks. And we've seen those data. I'm going to ask your thoughts about the study and those data. But at week 30, of course, there's re-randomization. Patients on the innovator either stay on the innovator or are randomized to switch to the biosimilar. And conversely, those that initially were randomized to the biosimilar then get randomized to either stay on the biosimilar or switch to the innovator. And we haven't seen any of the data from that switch portion of the trial yet, but we have seen some data from the head-to-head comparison. So Vip, I just ask your thoughts, knowing that the study designed some of the early data, what are your thoughts about strengths and weaknesses of this protocol?
So again, I think this is again exciting data for gastroenterologists. I think if we go back to the original trials for when this drug was approved, the phase 2 PK study was done in ankylosing spondylitis, and the phase 3 study was done in patients with rheumatoid arthritis who all co-prescribed methotrexate, which led to the extrapolation of indications. And so there were no patients with inflammatory bowel disease. This study is important because it takes a homogeneous group of patients, just patients with Crohn's disease, not a mixed pot, and it simply asks the question in patients naive to treatment with active Crohn's disease, standard criteria, CDAI of 220 to 450, who were naive to TNF therapy. They were randomized to the biosimilar or to infliximab, and they're, as you said, followed up to 14 weeks, and then there's a switch. So randomized, it's double-blind. The endpoints are relevant, but we can talk about the nuances of those in a moment, but they look at the CDAI response, which is a drop in 70 points in the CDAI between the two as a primary endpoint. And again, it's a non-inferiority study. It also looks at many other secondary endpoints, PK, safety, anti-drug antibodies, quality of life, and all those factors. And I think when they designed this study, they have gone about picking the non-inferiority margin a bit more scientifically, I guess. So they looked back at the original Accent 1 and the Sonic studies, and they looked at, what is the maximum placebo effect that you might see and the minimum effect that you might see from infliximab in this setting. And they came out with a delta of around about 40%. Taking half of that, so preserving half of the margin, they then powered the study to say they expect a sort of a 60% response rate at week 6 in the CDAI 70 with a 20% non-inferiority margin. So again, the endpoints are relevant, and it's purely in patients with Crohn's disease. Even more exciting parts of it will come downstream when, as you say, they will switch patients. There'll be another randomization where they take patients on innovator and they're randomized to continue or switch again. And patients on biosimilar who will be randomized to continue or switch. Those will be seen at 54 to 54 weeks.
I think you've done a great job outlining the strengths, but of course we're born to be critical of data, and maybe just take our viewers through what some of the limitations might be of this particular study.
Okay. Well, I think the first thing we talked about the CDAI response, so a response rate as a primary endpoint. It's pretty unusual in a efficacy or a phase 4 study to use response. Typically, we'd use remission in this setting. So I think that's probably one point of discussion. And if you look through most historical placebo-controlled trials in Crohn's disease, the margin for response would be a drop in 100 points in the CDAI, and which is a little bit more stringent than a drop in 70 points. So, one could argue that maybe remission should have been the primary and a slightly more stringent endpoint for response. I think you can see why they've done that. Again, it's no perfect study, and I think they've done the best with the resources. But taking the response at 6 weeks, and again, I think that's a relatively early endpoint in Crohn's disease generally. They can power the study so that the sample size can be smaller, so you can take a 60% response with a delta non-inferiority margin of 20%. They came out with a sample size of around 200 here, so out of the bat, it's a big study when you're talking RCTs and IBD in this day and age when recruitment rates are so poor. Nonetheless, by the end of the trial, when you have 4 arms, you're left with 50 patients per arm, and accepting there will be some attrition rates. There may not be enough power to look at the switching question at the end. Those are potential weaknesses, but I don't want to comment on those until we see the final results of the study. But I think those are the typical points that will come up.
At the end of the day, what does this trial tell us? I guess specifically, is it going to, if the results hold up as they have today, is this going to make us more confident in using biosimilars for treatment of IBD? Or do we need more? And so what are your thoughts about that?
I think the results of this trial will give us a lot of confidence in the GI community so far. So coming from having trained and worked in Europe all of my life to date, until the last 2 years, I guess the pressures of payers were slightly different in that the uptake of biosimilars has been far more avid and rapid for a whole host of reasons, but I think most of those driven by payers. And I think it's fair to say, particularly in the GI community, and I haven't got the data to back this up, but the uptake of prescribing biosimilars when you have a choice, so this is in the naive patient, are you going to give them innovator or biosimilar? I think the uptake has been slow in Canadian GI community for all the reasons that we've been discussing up to now. I think the results of this trial, certainly the first part of the study, where you say they've looked at absolutely everything, CDI response cut in different ways, remission, safety, PK data, adverse events, and there's this meets non-inferiority. It was non-inferior, and all of those aspects. I think this will give a lot of confidence in the GI community that out of the bat, it's fine to use biosimilar, and there's no difference to using innovator. So, I think the results of this study will support uptake of biosimilar prescribing by naive patients.
So certainly payers are going to, I think, be behind us. I think if you suggested before, but you're saying this might help to give physicians some reassurance about their use.
Yeah, I think it will, and as we said, there's been a real appetite to see randomized data in IBD, and I think this will reassurance to many prescribers that it's okay to prescribe a biosimilar rather than the innovator upfront.
So where do you see them being used? I mean, is this, what setting? So is this, again, I think there are 2 broad categories where you consider biosimilar use. One is the treatment-naive patient when you're choosing first therapy. And of course, the other, as we've alluded to, is the stable patient on an innovator and that concept of switch. So where do you see, I guess, in the current climate, biosimilars having a role?
Well, I think in the Canadian environment, it's in the first scenario, so taking naive patient and prescribing them either when you have a choice of biosimilar innovator. I think the uptake's going to be in that setting. I guess the switch question is interesting, and I'm sure we'll talk about interchangeability shortly, but I guess the question comes is, why would you take a stable patient and switch them unless you're absolutely forced to by payers, regulators, government bodies? I think it's a difficult conversation. The choice has to remain to the prescriber and to the patient, and a decision between the two. You and I, busy clinics today, having that, taking a patient who's doing very well on their innovator drug, and then trying to explain to them that they should switch over, despite randomized data. Why would you do that? If there's any change in the patient's condition, it will be attributed to a switch. With this specific trial, I think we have to hold reservation until we see the switch data at 54 weeks.
I think fair enough. And as I always say, it's a one-sided, one-way experiment. When you take a stable patient and change treatment, things can only get worse. So I think you're right that physicians will have a high bar for feeling comfortable with that particular decision in practice.